And we are live, Senators.
Okay, good morning. This is the Senate Health and Welfare Committee, and it's January 31st. Hard to believe that the first month of the year is coming to an end, really. But this week, we're going to be getting into a number of bills that are in our committee and beginning to take testimony on those bills. We'll also be doing some other things to keep us current. And this morning is an opportunity to hear from the administration, from DEVA, about what's happening with Medicaid after a prolonged period of time where people have not had to reapply. So why don't you introduce yourself for the record, and thank you for coming in and letting us know how we can help.
Thank you very much. This is Addie Stremlow, Deputy Commissioner of the Department of Vermont Health Access. It's very nice to see you all and meet some of you for the first time. In my capacity at DEVA, I oversee healthcare eligibility and enrollment, which includes the Vermont's health insurance marketplace, providing enrollment into Medicaid as well as qualified health plans with subsidies. I know we only have a few minutes this morning, so I will keep it pretty brief, but I'd be very happy to come back and walk through in more detail some of our planning around Medicaid renewals, which is what I'm here to speak with you all about this morning. I know there's a lot of discussion in the building and elsewhere about Medicaid renewals or redeterminations. So we wanted to just provide some basic information on that topic so you all can answer questions if you're asked. And again, we will provide those the materials to we have a dedicated website and a number of different resources that we will send to you all.
So Deputy Commissioner, I think that probably we should introduce ourselves because we do have a new committee. And I realize this is your first time here this year, so welcome. And we'll begin over here with Senator Gulick.
Hi, I'm Martine LaRock Gulick. I live in Burlington and I represent Chittenden Central.
Good morning, I'm Dave Weeks. I represent Rutland County and I come from Proctor.
Ginny Lyons.
Senator Terry Williams from Rutland County, and I'm from Polk.
Hi, Addie. Ruth Hardy from the Addison District.
Okay.
Thank you very much.
So go right ahead.
Okay, so I think many of you are probably already familiar with the concept of Medicaid continuous coverage during the pandemic. But in a nutshell, since spring of 2020, Medicaid agencies across the country have generally been required to keep people on Medicaid. So Vermonters have remained on Medicaid even if they no longer qualify. This measure, which we refer to as continuous coverage, was established by Congress back in the spring of 2020 in conjunction with increased Medicaid funding. And it was designed to help ensure as many people as possible could keep health insurance and access healthcare during the pandemic. So what's happening now is that protection is going away. Last month, Congress passed another bill, the Consolidated Appropriations Act of 2023, that ends the continuous coverage requirement. So starting in April, Medicaid agencies across the country, not just Vermont, will begin the process of checking people's eligibility for Medicaid. We refer to this as renewals. And this is a federally required process that happens annually, and it involves, just checking to see if those basic eligibility factors are still in place for members. This is what was suspended during the continuous coverage period. And I think it's really important to understand that none of the rules about who can be on Medicaid have changed or will be changing. This is just going back to normal operations and these annual checks to see whether the Vermonters on Medicaid are still eligible. We also want to be clear, just because of some of the information that's swirling, that this is a federal requirement that Vermont must follow. It's not a state decision. And this policy requires that all states, again, begin checking Medicaid eligibility. We would jeopardize our funding if we didn't. The good thing is that we've had quite a long time to be working toward this moment because it was previously tied to the public health emergency declaration, which kept getting extended, and we kept having kind of fits and starts around restarting these processes. So we've been able to develop a detailed plan, as I mentioned, that's posted on our website. And I'd be happy to come back and walk through that with you all. And even though we're just returning to normal operations, we completely recognize that many enrollees haven't had a renewal in 3 years, and some of our newer members have never had one. So we're taking a lot of steps to help with this, and we recognize that it's a change. Those measures generally fall into 3 areas. The first is communications, so making sure we have the correct contact information and special messaging and mechanisms to let people know about their renewal. The second is streamlining the renewal processes themselves, so maximizing use of data sources and minimizing the need to outreach people and ask for additional documentation. And the third is facilitating transitions to other coverage. And all of this is outlined in the plan, but I wanted to make a few just key points for you all this morning. The first is that Medicaid members will not be reviewed all at once. So we have over 200,000 enrollees at this point, and we need to renew all of them. So that's going to take place over the course of more than a year. 12 to 14 months is the schedule that we have outlined. And again, members will get kind of special communications leading up to the month of their renewal so that they're on notice. The second point is that we can't project the number of Vermonters that will no longer be eligible for Medicaid. Whether enrollees maintain Medicaid really depends on their personal circumstances and the participation in the renewal process. So it's going to be very important for enrollees to, check their mail. We've actually designed a special envelope with a red stripe on it for use in renewal, so it kind of stands out. And then the third thing I just wanted to really highlight is that if Vermonters go through this process and figure out that they're not eligible for Medicaid anymore, they will have the opportunity to enroll in other health insurance coverage. We have, I think some of you are familiar with this, but we really have an influx of federal subsidies right now to help Vermonters afford health plans on the marketplace. Over 90% of our enrollees are getting subsidies, and over a quarter are paying less than $25 a month. So that's part of it was originally the American Rescue Plan Act and then extended through the Inflation Reduction Act last summer. So I think overall, just to capture it, our key point is that Medicaid's not going away. We're returning to normal operations, and we're here to support our members through that. And we're also asking partners, advocates, providers, friends to spread the word and to help members understand what they may need to do to maintain their coverage. And we'd love to engage with you all in that effort. And again, we're happy to follow up with more specifics.
Thank you. Yeah, I'm not sure that I've heard from too many. I did hear over the weekend from a couple of folks with a question and that I could answer, fortunately. And so I just sent Alex the link, the webpage link that Ginger sent on Friday, and he's going to post it on our webpage. If you have any additional one-pager or information, would be very helpful. And I'm looking at Blue Cross and Blue Shield. If you have anything related to qualified health plans,
Sure.
That would be helpful. If you want to send it in to Alex, and we'll post it. That way, we'll cover more, more places and people. Questions?
Great.
Any questions? No, this is going to be. I can't imagine trying to sort out 200,000 people. Because I can see what's happening at home, and I can hear people saying, well, gosh, who do we call? How do we do this? And then you at the other end of all of that, will navigators be working on this? How is it all going to happen?
Yeah, we're hoping to kind of harness the entire healthcare enrollment community, and Assisters play a key role there. And we've been doing specific dedicated training with our Assister community about the plan for restarting Medicaid renewals. So I think you'll see on the website, and I'm happy to highlight it for you, a key portion of this is communications. And we have special postcards, a text messaging campaign, a number of different things that we're doing specific to this project.
Is the federal government helping with the communications piece, i.e. postage, mailing, postcards, or is that all going to be under the state?
From a financial perspective?
Yeah.
No. I
They're
mean, not in any specific way. I mean, obviously, Medicaid is a partnership program from a funding perspective, so there's always a piece that's federally funded. But they've been helpful with messaging, talking points and that sort of thing. But the logistics of getting everything ordered and designed and everything else is happening here at DVHA.
Okay, question here. Senator.
Just one quick question. So over the past 3 years, I understand you're returning to normal operations. That's a good thing. Over the past 3 years, have the eligibility rates changed? And if so, have any of those criteria been articulated to the 200,000 folks?
Yeah, that's a great question. And thankfully, the answer is no. The eligibility standards are the exact same.
Okay, very good. Thank you.
Yeah.
And we're going to see all kinds of discussion now that there's an inflationary factor that's gone up so greatly, but okay. Any other questions for Deputy Commissioner Strumlow? We're good? Okay, so thank you for the information. And as I said, if you have other one-pagers or, frequently asked questions, things that you can send to us, that will be very helpful as we help our constituents. So, thank you. And
That sounds great. Thank you.
Yeah, well, I hope that people who are listening understand that this is a process. It doesn't kick anybody off of Medicaid in April, does it? People are on Medicaid until their reapplication is complete. How does that work?
Yeah, the first batch, they will get their renewal. Again, it's divvied out over the course of 12 months. So a few thousand people in April will start to get renewal notices. If it turns out they're not eligible or they don't respond, the first closures would be June 1st, 2023.
Okay, so once people get the postcard or the contact, it's really important that they follow the rules or follow what's on the postcard and go ahead and reapply. So that's important. Yep. And then there's a full year of this going on. 12 months, 200,000 people. We're all going to see some frustration and we're going to see some exasperation, and but we're all going to need patience. So okay. Any other questions, comments? Okay, so we'll be in touch, and please thank Ginger for sending that information along, and we'll stay connected. Thank you very much.
Thank you all.
Okay, take care. All right, so we're ready.
All right,
We've run that sit together.
We do.
All right. So we're now moving into the second bill that we have taken up. This one may take us some time, so we've allotted an hour, but it might take more than an hour. Just because it is a long bill, it has a history, it might be a little complicated, but not for us, This is commonly known as the reproductive shield or protection law, and the bill comes as a result of all of the national activity and state activity around Roe versus Wade and protection for health caregivers who might be, or patients coming from out of state to receive services in Vermont, and protecting providers in state and as they carry out their work, in particular with regard to abortion services and other protected healthcare services. So what we'll do is we will have Jen and Amarin go through the bill with us, and we'll try to ask questions of what does this mean? We'll start out at maybe the 1,000 to 2,000 foot level. We really do want to get into the bill as much as possible. So you can take us from up here to down here as you go through the bill. We'll ask questions and then we'll see how far along we get. Does that make sense to you?
It does.
Okay.
Would you like us to screen share
Sure.
the document?
Yeah, that'd be great.
That will take me just a moment.
And as I shared with you, if I brought this down from the floor when we got the bill introduced, and so it might be helpful. S37. And we do have it on our webpage. So this bill, frankly, is a priority bill for us to look at and to try to get as much information as we can. So you have the one-page overview. You want to start with that?
Certainly, that would be a good. So make sure I'm not going to set this up so we get all the echoing.
And while we're waiting, there is a companion bill, judiciary companion bill that's beginning in the House, so in the House Judiciary Committee. And there'll be some places that Jen and Amber talk about that I'm gonna, in particular, and Jen and Amber are gonna have to pay attention to maintaining some alignment with that bill. That will be.
Yeah, just to be clear, it's not companion in the sense that we often mean companion where it's the same bill in the House and Senate. It's sort of a.
Oh, two different bills.
It's a different, yes, it's a different bill focused on the judiciary aspects, that kind of litigation aspects and law enforcement.
Okay.
All right, perfect, thank you.
So for the record, Amber Abergilly, Legislative Counsel. I made this brief one-page overview so that when you ever need to refer to just what's in this bill, you can go through and see the highlights here. So I'll start with the highlights. As you may recall from when we first did our staff introductions, I handle a portion of the healthcare portfolio, and our Chief Counsel, Jen Carby, also handles certain aspects of the healthcare portfolio as well. So she will have some sections of this bill and I will have some sections of this bill, and so we'll be walking through this together. So to start off, this is S37, an act relating to access to legally protected healthcare activity and regulation of healthcare providers. As Jen and Senator Lyons mentioned, there is a House bill going through judiciary that is focused on the judiciary aspects of SHIELD laws. And this bill is more focused on the healthcare arena and professional regulation of healthcare providers. So first, this bill proposes to, one, add definitions to statute for the terms gender affirming healthcare services, legally protected healthcare activity, and reproductive healthcare services. This is an important one because this is a lot of the basis for the provisions you're going to see through the rest of the bill, so you understand the scope of what we're talking about when we move through these provisions. I will also note that there is an identical section in the House Judiciary SHIELD law bill. So this is that instance where we need to make sure that those two definitions continue to align as the bills move through each chamber. It's just to make sure that when we finish at the end of the session, we don't enact two laws that have conflicting definitions. Or if they are conflicting, they're conflicting in a way that legally makes sense.
Appropriately.
Appropriately conflicting. So next, prohibit a medical malpractice insurer from adjusting a healthcare provider's risk classification or premium charges in certain circumstances related to the provision of legally protected healthcare activity. Require that a health insurance plan covers gender affirming healthcare services and abortion related services. Prohibit a healthcare provider from being subject to professional disciplinary action for providing or assisting in the provision of legally protected healthcare activity. Establish a new Unfair and Deceptive Act regarding pregnancy centers. Require the Department of Health to submit a report regarding access to abortion, birth care, and gender affirming healthcare services. Require the Board of Medical Practice, in consultation with the Office of Professional Regulation, to submit a report regarding the state's participation in interstate compacts and the provisions of this act. Establish a new subchapter in Title 26 regarding the dispensing of emergency contraception. Require Vermont's public institutions of higher education to adopt gender-affirming healthcare and medication abortion readiness plans for their students, and limit the circumstances under which covered entities may disclose information regarding legally protected healthcare activity. And within this bill, anytime we are using the phrase legally protected healthcare activity, that includes reproductive healthcare services and gender affirming healthcare services. So that is the very 1,000-foot level view of what is in this bill. So now I'm going to move over to the bill language itself. Oh. Now I'm going to move over to the bill.
We're good.
So, okay, great. So I'm going to start off with the first few sections. There's a long description that of the statement of purpose. That's basically the information that I just read out. Gives you an idea of what's within the bill. But moving down into the sections of the bill, section 1 is definitions. Here are those definitions that you are currently going to see both in this bill as well as the House Judiciary Bill. This would add section 150 to Title I, legally protected healthcare activity. First, we're adding a definition of gender affirming healthcare services, meaning all supplies, care, and services of a medical, behavioral health, mental health, surgical, psychiatric, therapeutic, diagnostic, preventative, rehabilitative, or supportive nature relating to the treatment of gender dysphoria. Gender affirming healthcare services does not include conversion therapy as defined in Title 18, Section 8351.
What does that mean? I don't mean, I don't mean the no reciprocation, but I just don't understand what it means.
Yes,
So
so
what is included in that care?
this care is related to the treatment of gender dysphoria. I think as you move through this bill, you will be hearing from witnesses who will talk about how these definitions apply in the real world clinical context. And that will help you understand the scope of this definition and how this definition works or does not work for the scope of what you're looking to do with this bill. So that is an excellent question, but I am not a medical care provider, so I hesitate to try and say what exactly this covers. And I believe you may be hearing from some witnesses at some point who might be able to explain more in real detail that you can understand in sort of real world context. What population of people are we talking about, and what population and what type of services are we talking about around this type of care?
And that's accurate. So we will get witnesses in who can answer that question and who deal with this issue on a regular basis. You and Senator Gulick and Senator Weeks are each at a disadvantage because this committee did go through a discussion about gender dysphoria, gender affirming care last session. And so we will bring witnesses in, physicians in particular, who can answer your questions.
I will say, as we were moving through some of the sections of this bill, some of these provisions are based on a Massachusetts law that was passed last year. So there are instances like this one where we modeled this language after the Massachusetts law. And so you may look at these definitions as we're moving through here and say, does this work in Vermont and in the populations we have for the services we provide? So it's important to note that this was not a definition that we in Ledge Council created, but one that we have taken from a law from another state. And as always, when we take something from another state, we should see whether it fits the circumstances of our state. Next on page 3 is legally protected healthcare activity, meaning the exercise and enjoyment or attempted exercise and enjoyment by any person of rights to reproductive healthcare services or gender affirming healthcare services secured by the state or the provision of insurance coverage for such services. Or any act or omission undertaken to aid or encourage or attempt to aid or encourage any person in the exercise and enjoyment or attempted exercise and enjoyment of rights to reproductive healthcare services or gender affirming healthcare services secured by the state, or to provide insurance coverage for such services, provided that the provision of such a healthcare service by a person duly licensed under the laws of the state and physically present in the state, and the provision of insurance coverage for such services shall be legally protected if the service is permitted under the laws of the state, regardless of the patient's location. Once again, this is the definition that you may hear from witnesses about ways to, does this definition work for our providers and constituents of the state Does it need to be amended? Could it be clearer? And so that is the legally protected healthcare activity that we're going to hear about for much of the rest of this bill.
So they not only have the right to this, but is Medicaid going to pay for it?
We will get down to later on in the bill. We'll get to what we're talking about in terms of insurance coverage and Medicaid coverage.
Right now, so Jennifer Carvey, legislative counsel, so we're setting out the definitions that are going to be used throughout the bill so that we don't have to use as many words to kind of incorporate these thoughts
I'll
as
be
we move through the bill. But this would be adding these definitions in Title I of the Vermont statutes annotated, which means they will apply across all of our statutes. So we don't have to reenact these same definitions in different chapters or different titles throughout the statutes.
Next is the definition of legally protected healthcare activity, or sorry, a continuation of the definition of legally protected healthcare activity to specify that this does not include any service rendered below an applicable professional standard of care or that would violate anti-discrimination laws of the state. That's to say, providing the service, it must still be done in a competent and in a competent manner and up to the standards of the profession for it to be considered protected. Reproductive healthcare services means all supplies, care, and services of the medical, behavioral health, mental health, surgical, psychiatric, therapeutic, diagnostic, preventative, rehabilitative, or supportive nature relating to pregnancy, contraception, assisted reproduction, pregnancy loss management, or the termination of a pregnancy. So those are our definitions. You're going to see those terms referred to in Moving into section 2, we're moving into the context of the world of medical malpractice. So first, we're adding a new section or a new subdivision, I should say, into section 4722 of chapter 29 of Title 8. This is regarding insurance trade practices. In here, we're adding a definition of abusive litigation because this term is going to be used in the following section. This is another instance of a definition that is in this bill that is also in the House Judiciary Shield bill. So another definition that we're going to have to make sure that we are in alignment as these bills are moving.
So is abusive litigation a new term?
It has not been, I should say, I'm not sure if it is defined elsewhere in statute specifically. I know we are adding this definition of abusive litigation in the context of legally protected healthcare activity. Abusive litigation means litigation or other legal action to deter, prevent, sanction, or punish any person engaging in legally protected healthcare activity by filing or prosecuting any action in any other state where liability in whole or in part, directly or indirectly, is based on legally protected healthcare activity that occurred in the state, including any action in which liability is based on any theory of vicarious, joint, or several liability derived therefrom, or attempting to enforce any order or judgment issued in connection with any such action by any party to the action or any person acting on behalf of a party to the action. A lawsuit shall be considered to be based on conduct that occurred in the state if any part of any act or omission involved in the course of conduct that forms the basis for liability in a lawsuit occurs or is initiated in the state, whether or not such act or omission is alleged or included in any pleading or other filing in the lawsuit.
This concept is designed to states from litigating against Vermont in response to the act, Central Act.
Right. I would say, so as we move into the next section, just for context, we're talking about providers who provide legally protected healthcare activity in this state. Say a Vermont provider assists a resident of another state when they're visiting in Vermont with a legally protected healthcare service. Right? Say of medication-assisted abortion, that the resident from another state brings medication home with them to their home state,
Good.
then whatever happens to be the laws of that state, if that state determines that, again, by their laws, that a provider should not be providing medication-assisted abortion services to one of their residents, regardless of the legality really of what's happening in that state.
So-
And say they're trying to sue their Vermont healthcare provider over the services that they provided to that resident of another state. So we're looking at a context where, say, under the rules of the other states, they have no legal right to be trying to sue, or say they do have a legal right, but how they're proceeding with it is abusive in nature.
Okay, let me.
Is that
Again, tell
helpful
me-
for context?
Tell me if I'm like too far ahead of the card, you know, okay, so for example, if Cigna, and let's say Cigna is based out of a different state, right? I think, you know, their headquarters is in a different state. And they see this bill and they say, medical coverage at no risk. No risk, which means no risk, some language about, you know, to me means like you can't escalate their premiums based on this information. And they file a suit. And the suit affects Vermont. Does Vermont consider this an abusive litigation, or whatever the right word is? It's an abusive. Can you go back up just a little? I just wanna make
It
sure.
might help if I go through the next section, because right
Okay.
now we're just defining what abusive litigation is.
Yeah, I'm just trying to understand who it applies to. Is it really applied internal to the state, or is it applied as other states see Vermont and have cross-border medical coverage? You know, medical, yeah.
So
coverage.
this is not focused on health insurance coverage of the individual patient right now. What Amber's going to show you in this next section is how this term abusive litigation would be used in the statute that it's being
Yeah.
added to. There are some provisions coming up around health insurance specifically.
For example, prohibit a medical malpractice insurer from adjusting a healthcare provider's risk classification.
Yes.
And if Cigna says, no, that's unfair, this is a change. Is this, and they say, hey, it's a change, would that be abusive litigation?
Let me move into the next section. So this would amend section 4724, unfair methods of competition or unfair or deceptive acts or practices defined. So this would prohibit an insurer, and in this context, we're talking about medical malpractice insurance. Okay, so unrelated to insurance of any patient. And in here, it's saying that companies that provide medical malpractice insurance cannot discriminate against a healthcare provider or adjust or otherwise calculate a healthcare provider's risk classification or premium charges on the basis that the healthcare provider provides or assists in the provision of legally protected healthcare activity in this state that is unlawful in another state, or that another state's laws create potential or actual liability for that activity, or that abusive litigation against the provider concerning legally protected healthcare activity resulted in a judgment against the provider.
So basically what this is, I'm sorry.
No, jump in.
Okay, so basically what this is saying, is we've created this idea of legally protected healthcare services. And this is saying a medical malpractice insurer that's covering the healthcare provider can't increase the amount that they have, that provider has to pay for their medical malpractice coverage based on the fact that that provider is providing this legally protected healthcare. Even though there may be the increased potential for litigation based on other states' laws, what this bill and the other bill are both trying to do is create as much protection as possible for Vermont providers. So a piece of that is saying to the medical malpractice insurance community, sort of largely, not just carriers based in Vermont, but carriers covering Vermont providers, you can't make these providers pay more for their medical malpractice coverage just because they're providing legally assisted healthcare services, or because they're the subject of an abusive litigation lawsuit from another state based on providing legally protected healthcare services. So it's really looking at trying to keep the Vermont providers as whole as possible for providing healthcare services that are allowed in this state. Does that help?
I'll let you continue. We'll circle back. Thanks.
There will be a lot of conversation on all of this, but we're happy to try to make it as clear as possible.
Yeah, we haven't seen the process here.
No, you're asking some very important questions for clarity, and, you know, keep doing it, because then we know where we're gonna have to come back and we'll hear testimony to help, to help. Yeah.
Thank you.
Really important.
All right, so now we're moving into section 2, we're getting into insurance coverage. So first, we're adding section 4088M to Title 8, coverage for gender affirming healthcare services. Definitions in this section. Once again, we're referring to that gender affirming healthcare services definition that we covered in section 1. In terms of insurance plans, we're talking about Medicaid and any other public health care assistance program, any individual or group health insurance policy, any hospital or medical service corporation or health maintenance organization subscriber contract, or any other health benefit plan offered, issued, or renewed for any person in the state by a health insurer as defined in Title 18, Section 9402. For purposes of this section, health insurance plan shall include any health benefit plan offered or administered by the state or any subdivision or instrumentality of the state, such as Vermont State Employees Health Insurance. The term shall not include benefit plans providing coverage for a specific disease or other limited benefit coverage, except that it shall include any accident and sickness health plan. Coverage in subsection B, a health insurance plan shall provide coverage for gender affirming healthcare services. Subsection C, cost sharing. The coverage required by this section shall not be subject to any co-payment, deductible, co-insurance, or other cost sharing requirement or additional charge. As in case there are any questions before I move to the next section. All right, section 4, continuing on in the world of health insurance. Section 4099E is added to Title 8, coverage for abortion and abortion-related services. Subsection A, definitions. As used in this section, 1, abortion means any medical treatment intended to induce the termination of or to terminate a clinically diagnosable pregnancy, except for the purpose of producing a live birth. 2, health insurance plan, identical to the section we just read, Medicaid and other health insurance plans.
Yeah, no, go ahead.
Can I back up just a sec? Because you
Yes.
kind of moved quick.
Yes.
Back to section B on coverage. I'm sorry, C on cost sharing.
Yes,
Is that legal that we can mandate a health provider to do something at essentially no cost? Is that, the state can mandate?
so
Is that,
this is a good point. Let me back up slightly to put this in the context of some of the discussions that we've had previously about what world are we talking about when we're talking about insurance. So when we're talking about mandating insurance by the state, we're talking about coverage within plans that are in our fully insured worlds. We're talking about fully insured large group insurance, small group and individual insurance on the exchange, and in this instance, we're also talking about Medicaid. When there are a couple of aspects of state regulation when it comes to whether we're talking about covering an entirely new benefit or whether we're talking about shifting the cost sharing amount for a benefit that is already required. So for the insurance that's in the Vermont Health Connect, when we're talking about small group and individual insurance, that insurance coverage is under the Affordable Care Act regulation. So in that instance, if the state is adding a new mandated benefit, then there is the requirement that the cost of that new mandated benefit be defrayed by the state. What that looks like operationally, I'm not entirely sure. So if, for example, the plans, and there's also a difference between the state mandating coverage and plans already covering some services. So if this is an insurance item, an insurance category that has not been covered by small group and individual insurance plans in the future, or excuse me, that is not presently covered, then we are looking at mandating a new benefit for those plans, in which case we would be subject to that cost of rail requirement.
Okay, so
So I think that would be an excellent question to, if you hear from the Department of Vermont Health Access, who runs the exchange, and then also if you hear from insurance providers.
But if I think the question that I understood Senator Rubin asking was about whether we can require, I think you were reading cost sharing to say the provider has to provide the service without getting paid for the service.
That's what it was.
So cost sharing is the amount of out of pocket that the patient has to pay versus how much the insurance plan covers. So the provider's still getting paid for the service either way, but when there's no cost sharing, it means it all goes through the insurance plan, and the cost effectively gets spread out across the premiums for all of the payers, you know, in future years. Rather than if there being a copay amount of, you know, $50 or 10% or 20% co-insurance requirement, or subjecting it to the deductible. But the provider always gets paid. That's not what's affected here. The question is how much comes out of the patient's own pocket in addition to their premium.
I get that.
Okay. And so, yes, we
I'm just
can,
asking you, is that legal?
Yes,
State-
Yes.
Okay.
and we have in a number of other insurance mandates and provisions as well.
Yeah, it's like, breast exam, what else? We've got a number of benefits.
Right, there are certain ones that now are also required to be covered first dollar by the ACA. So I think, you know, mammography and things like that fall under there. But yes, we have both required no copay or limited the amount of copay for a number of different services. And you will likely hear from the insurers about their thoughts as well.
Senator Gulick, go ahead.
Actually, no, I was just stretching my arm.
Oh. Senator Hardy, were you checking out?
No, I was just gonna say, and when you're asking the question of, is it legal? I just want to remind you that we make the laws. So you know, there are obviously some cases
Oh, I'm
where
fine.
federal law prohibits us from doing something, but if we want in a bill to require something, as long as it's not prohibited by federal law in most cases. Or, yeah.
It does bring up the question about the benefits plan that we have through the ACA and then what we're adding to it. I'm sure we'll hear from insurance companies, we'll hear from DEVA, we'll hear from folks so we can understand what the implications of that little paragraph are. Yeah.
Right, we'll move back to section 4, coverage for abortion and abortion-related services. We were, I believe, down in insurance, the definition of insurance plan. This is the same definition of insurance plan as you just saw in the previous section. Coverage, a health insurance plan shall provide coverage for abortion and abortion-related care. In subsection C, talking about cost sharing, the coverage required by the section shall not be subject to any co-payment, deductible, co-insurance, or other cost sharing requirement or additional charge. Example to the previous section. Next, section 5, state plan amendment. The Agency of Human Services shall seek a state plan amendment from the Centers for Medicaid and Medicaid Services or federal authorities if needed to allow Vermont's Medicaid program to provide coverage consistent with this act. Next, we are moving on into the world of professional regulation of healthcare providers. Section 6 is amending section 129A of Title III on professional conduct. I'm now on page 9. Healthcare providers. Notwithstanding subsection B of this section or any other law to the contrary, no healthcare provider shall be subject to professional disciplinary action by a board or the director, and that's the director of the Office of Professional Regulation for context, solely for providing or assisting in the provision of legally protected healthcare activity.
And just a reminder, when we're talking about the board, we're talking about the board of,
So,
what boards?
right, boards within the Office of Professional Regulation. You have the director that directly oversees regulation of some professions with, in consultation with advisors. And then you also have specific boards for a profession. So when we say board or director here, we're either talking about the professional board for that profession or the director, and that depends what occupation we're talking about.
Yeah, it takes a little while just to figure out what's under Office of Professional Regulation and what's under the Board of Medical Practice. And so we'll probably have those folks in to also talk about the bill, and you'll get a better idea of where doctors of osteopathy live versus MDs live versus PAs versus APRN. So
Sounds like fun.
oh, that's fun. Okay, so we'll do that.
So a board or the director shall not take adverse action on an application for certification, registration, or licensure of a qualified healthcare provider based on a criminal or civil action or disciplinary action by a licensing board of another state that arises from the provision of or assistance in legally protected healthcare activity. And
Yeah, no, go right ahead. No, just go right ahead and ask your question. If it gets too much, we'll.
So I'm just curious, so I understand this, but the reverse, where a healthcare provider declines to provide care, there's no language in here that people, physicians, medical providers can make their own decision on what type of medical care they provide. I'm curious if it's kind of maybe an omission or maybe it's purposeful. I'm not really sure, but taking the 180-degree view of whether a physician could or couldn't, but not having any language, I don't understand where that leaves that medical provider. I really don't.
I'm trying to think, so
Is that a judicial bill or not?
Yeah, I'm sorry.
I think so. I mean, I think in general, there's not typically a requirement to provide any particular service, but there's also a requirement not to abandon a patient. So you'd have to help a patient sort of get to the next, get to another provider. But I understand your question to be, should there be something in here that also says no action?
No, I'm just curious about the omission of if that's important or not important. But
I think it'd probably be a good question.
But we can also ask the board.
Exactly. I think it's a good question for the board, the Board of Medical Practice and the Office of Professional Regulation when you have them in, just to say, is that something that we should affirmatively address in here?
Write that down next to boards. So you ask that question on there. I'm sure we get it. It's a good question.
and then lastly, in this section, we have definitions. Healthcare provider has the same meaning as in Title 18, ESA 9496. And then legally protected healthcare activity has the same meaning that we saw in Section 1 at the beginning of the bill. Next, in Section 7, we have it's identical, but this is adding a section, amending a section in Title 26, Section 1354, unprofessional conduct. This falls under these sections relating to the Board of Medical Practice. So the previous section was about the Office of Professional Regulation and those professions and occupations for healthcare providers under their purview. And then Section 7 is for those healthcare providers that fall under the jurisdiction of the Board of Medical Practice. So you have the identical language here, notwithstanding any other law to the contrary, no healthcare provider shall be subject to professional disciplinary action by the board solely for providing or assisting in the provision of legally protected healthcare activity. And then, once again, the board shall not take adverse action on an application for certification, registration, or licensure of a qualified healthcare provider based on a criminal or civil action or disciplinary action by a licensing board of another state that arises from the provision of or assistance in legally protected healthcare activity, and has the same definitions.
This is where I will ask the question I've asked before, and that is around any compact relationships that we have. At some point, we want to get into what the compact might mean or not mean.
Yes, so Vermont is participating in 2 interstate compacts that relate to healthcare providers. First is the Interstate Medical Licensure Compact, which covers our physicians, and then also you have the Nurse Licensure Compact, which covers nurses but not APRNs or LNAs. And so those compacts are, I don't know if you've covered a compact in here yet this
Not yet.
session. The concept being that a number of states all agree to participate in a compact that's an agreement that says each member state may provide healthcare providers in this context within their state with a multi-state license, meaning that they can practice in any of the other member states with that multi-state license rather than going and getting an individual state license from each other state that they practice in. Particularly in the context of in New England is pretty small. You have people crossing borders fairly often to provide services. So there are requirements within those compacts around whether you're eligible for a multi-state license, depending on any discipline on your professional license in any state, whether you've had any criminal convictions, whether felonies or misdemeanors related to your profession. So as you will see, there is a report requirement later on in this bill, but understanding what is in those compacts and how those compacts will interact with the provisions of this bill is important. So you will hear more on that later, I'm sure, during witness testimony. The next section, section 8, is regarding pregnancy centers. So this would add a, this is within consumer protection statutes. This would add a subchapter 11, pregnancy services center fraud. First, there's definitions, section 2491. This is all, this would all be an entirely new subchapter. As used in the subchapter 1, abortion means any medical treatment intended to induce the termination of or to terminate a clinically diagnosable pregnancy except for the purpose of producing a live birth. 2, client means an individual who is inquiring about or seeking services at a pregnancy services center. 3, emergency contraception means any drug approved by the U.S. Food and Drug Administration as a contraceptive method for use after sexual intercourse, whether provided over the counter or by prescription. Health information means any oral or written information in any form or medium that relates to health insurance or the past, present, or future physical or mental health or condition of a client. Limited services pregnancy center means a pregnancy services center that does not directly provide or provide referrals to clients for abortions or emergency contraception. 6, pregnancy services center means a facility, including a mobile facility, where the primary purpose is to provide services to individuals who are or may be pregnant, and that either offers obstetric ultrasounds, obstetric sonograms, or prenatal care to pregnant individuals, or has the appearance of a medical facility. A pregnancy services center has the appearance of a medical facility if 2 or more of the following factors are present. A, the center offers pregnancy testing or pregnancy diagnosis, or both. The center has staff or volunteers who wear medical attire or uniform. The center contains 1 or more examination tables. The center contains a private or semi-private room or area containing medical supplies or medical instruments. The center has staff or volunteers who collect health information from clients. The center is located on the same premises as a state licensed medical facility or provider, or shares facility space with a state licensed medical provider. Premises means land and improvements or appurtenances or any part thereof.
What's I don't, if it's a spoiler alert, but I don't understand why that what the relevance of that definition is in this overall conversation. I don't know if there's any insight. I just don't understand. It's like.
So just to help with that, because I think we're getting into a pattern now where we see definitions, then we have the definitions put into a broader context. So the next section will take those pregnancy centers and put them into context. And then it's confusing. We all get confused with that, including me. So we'll start, we have these definitions, now we're going to see how they're used, and then it will either become clear or not.
So the next section, 2492, Unfair and Deceptive Act. Subsection A, is an unfair and deceptive act and practice in commerce and a violation of section 2453 of this title for any limited services pregnancy center to disseminate or cause to be disseminated to the public any advertising about the services or proposed services performed at that center if the management of the center knows or by exercise of reasonable care ought to know it is untrue or clearly designed to mislead the public about the nature of services provided. Advertising includes representations made directly to consumers, marketing practices, communication in any print medium such as newspapers, magazines, mailers, or handouts, and any broadcast medium such as television or radio, telephone marketing, or advertising over the internet, such as through websites and web apps. Subsection B, the Attorney General or State's Attorney has the same authority to make rules, conduct civil investigations, and bring civil actions with respect to violations of subsection A of this section, as provided under subchapter 1 of this chapter.
Can you explain what section 2453 is referring to? Because it's not in this bill, but it is in what, Title 8?
Title 9.
Title 9, sorry.
Yeah. So these are
Okay.
consumer protection. If you would
Yep.
like, I could pull up that section and share that if that would be helpful, or we can circle back when we're digging deeper
We'll
into
circle
the
back,
section.
but it's a section of statute that exists currently, and we're just
Yes.
referring to it, so we don't have to go back.
Oh, man,
Now go ahead.
I'm just curious. So if there's, if an issue like this is covered in Title IX, what's the relevance of reintroducing it into a bill like this? Why duplicate?
Title IX has a bunch of provisions about what are considered to be unfair and deceptive acts in
Okay.
different consumer protection contexts.
Okay,
So this would be adding a new situation where you have an unfair and deceptive act that.
yeah, but where is the, I don't see a new.
That's the,
Oh, okay,
that,
gotcha.
that's
The limited service.
yeah, so it's adding that, you're right, okay. No, good, no, good questions, these are important.
Thank you.
Certainly. Are there any more questions on this section before we move? We're going to be moving into a new. That's next. Okay. So next, section 9, and we're beginning a section that has reports. So the first is on or before January 15th, 2024, the Department of Health and the Green Mountain Care Board shall, following consultation with relevant stakeholders, submit a report to the House Committee on Healthcare and the Senate Committee on Health and Welfare, identifying areas of the state in which people do not have access to abortion or birth care or gender-affirming healthcare services within a 50-mile radius, including recommendations to facilitate access to those services in the identified areas.
Can I just add that the importance of this is that we're seeing, when we talk about gender affirming healthcare services, we're talking about a fairly young population, so adolescent population, so having.
Could be any age.
It can be any age,
Yeah,
but
no.
it's the numbers of that, right now, the wait list, for example, is pretty high in the adolescent group, so yeah, it's important to have some counseling or support services or something available. That's why the 50 mile.
So the intent of the report, does the report come with a list of communities, or does it come like provide a number of residents, or what's the, I mean,
It says identify areas of the state.
right, so you need, so what do? They just put a 50-mile radius around every, and then that's on a map, and that's the end of the report, or I just don't really, I get the intent, but I don't understand what the product is gonna look like. I mean, what are you really asking them to do? Just create a map showing 50-mile radiuses around providers?
The way the language is currently written, it's to identify areas of the state where people do not have this, and then recommendations to facilitate access to those services. So how the Department of Health and the Green Mountain Care Board interpret this report requirement is probably a good question to ask them.
Okay, no, I
If the
just-
language is not specific enough for them to provide something either that will be helpful to you or that makes sense to them, then I think you might want to look at amending this language so that you understand what outcome,
Yeah.
what product you will have at the end.
Okay.
Section 10 this is another report requirement. On or before November 1st, 2024, the Board of Medical Practice, in consultation with the Office of Professional Regulation, shall submit a report to the House Committee on Healthcare and the Senate Committee on Health and Welfare with findings and recommendations for legislative action to address any concerns regarding the state's participation in interstate licensure compacts as a result of the provisions of this act, specifically the state's participation in the Nurse Licensure Compact in Title 26, Chapter 28, Subchapter 5, and the Interstate Medical Licensure Compact pursuant to 26 VSA Chapter 23, Subchapter 3A. As we mentioned earlier, understanding the
Yeah,
connection between those.
To me, the difficult piece is pass legislation, then get the report back and find out there's something really urgent, but that's the way it is.
Right, and I think the language that you're looking to pass right now is to protect and shield these providers. So if the result of the report is that you need to do more, I don't think that necessarily undoes what you have already put in place.
Go ahead.
Is it okay if are you saying to me or to Amber? I just wanted to add that
Yeah, go ahead.
Lauren Hibbert is aware of this. This is mostly a placeholder to make sure that we get back to this issue, and I think she may have some
That's why I keep
language.
bringing it up.
Yeah, yeah.
That's good.
She's well aware that this is a potential issue.
Okay.
Great, Amber's now passing the baton to me, so I will take over on page 14 with emergency contraception. This adds, and section 11 adds a new subchapter in the Title 26, Chapter 36, which is the pharmacy statutes. It adds a new subchapter on emergency contraception. It starts out with some definitions. Emergency contraception as used in the subchapter means any drug approved by the U.S. Food and Drug Administration as a contraceptive method for use after sexual intercourse, whether provided over the counter or by prescription. And a physician is a physician licensed under Chapter 23, which is the MDs, or Chapter 33, which is the doctors of osteopathy of this Title 26. So the first provision in this subchapter after the definitions is section 2078, emergency contraception statewide standing order. This would have the Department of Health ensure the issuance of a statewide standing order to authorize the dispensing of emergency contraception by a licensed pharmacist. And the statewide standing order must include written, standardized procedures or protocols for the dispensing of emergency contraception by a licensed pharmacist. So that first part is just saying the Department of Health has to make sure this happens. In subsection B, it says notwithstanding any provision of law to the contrary, the Commissioner of Health or a physician designated by the Commissioner shall issue the statewide standing order that may be used by a licensed pharmacist to dispense emergency contraception in accordance with the subchapter. And notwithstanding any provision of law to the contrary, a licensed pharmacist may dispense emergency contraception in accordance with the statewide standing order that was issued pursuant to subsection B. So subsection A says health department is going to make sure this happens. Subsection B says either the commissioner or a physician designated by the commissioner will issue the standing order, and subsection C, specifically subdivision C1, says that a licensed pharmacist can dispense the emergency contraception if there is the statewide standing order. And it says that prior to dispensing emergency contraception, the pharmacist may complete a training program approved by the Commissioner of Health. This language is based on what, as Amber said earlier, what Massachusetts had passed. So you can look at whether you want a may or a shall there. But this says that a pharmacist may complete a training program approved by the Commissioner of Health. And that training must include proper documentation, quality assurance, and referral to additional services, including appropriate recommendation that the patient follow up with a medical practitioner. And it requires a pharmacist dispensing emergency contraception under the subchapter to report annually to the Department of Health at the time and in a manner established by the department, the number of times the pharmacist dispensed emergency contraception during the preceding calendar year. Reports made under this subsection shall not identify any individual patient. The reports must be kept confidential and are not public records and are not subject to the Public Records Act. Then in subsection E, it says except for an act of gross negligence or intentional misconduct, a pharmacist who acting in good faith dispenses emergency contraception shall not be subject to civil or criminal liability or professional disciplinary action related to the use or administration of emergency contraception.
Go ahead.
So who determines if that act was appropriate, legal?
Gross negligence.
Well, if somebody, somebody looking to bring a charge against the provider would, or against the pharmacist would be the first one to make the determination of whether they thought there was gross negligence or intentional misconduct, in which case either in a civil complaint, an individual, or in a criminal complaint, criminal liability, state's attorney or attorney general or professional disciplinary action, they would decide whether they thought the activity met the standard for gross negligence or intentional misconduct. And then it would be up to a court in the civil or criminal context or the licensing boards to determine whether the activity met that standard. It's a pretty high standard.
Thank you.
Sure. And similarly, except for an act of gross negligence or intentional misconduct, the commissioner or a physician who issues the statewide standing order shall not be subject to civil or criminal liability or professional disciplinary action for issuing the order or related to the use or administration of emergency contraception. So subdivision E1 was about the pharmacist. Subdivision E2 is about the commissioner or other physician who issues the order. And then subsection F allows the Department of Health and Board of Pharmacy to adopt rules in accordance with the Administrative Procedures Act as needed to carry out the provisions of the subchapter. You want me to keep going?
Yeah.
We're good. Okay, great. So next we have section 2079. This is emergency contraception and vending machines. This would authorize a retail or institutional drug outlet licensed under this chapter, so it's basically a pharmacy, but these are terms that are already used in the pharmacy statutes, may make over-the-counter emergency contraception and other non-prescription drugs or articles for the prevention of pregnancy or contraception available through a vending machine or similar device. And this would direct the Board of Pharmacy to adopt rules in accordance again with the Administrative Procedures Act to regulate the location, operation, utilization, and oversight of the vending machines and similar devices described in subsection A in a manner that balances consumer access with appropriate safeguards for theft prevention and safety. Oh, and one thing I should have mentioned on the statewide standing order, we did used to have a statewide standing order on, or similar provision on emergency contraception. That was repealed back in, I think, 2015 because emergency contraception became available over the counter. So there is some emergency contraception available over the counter, but there is also a type of emergency contraception, the trade name of Ella, that is only available by prescription. And so reinstating a statewide standing order would allow that to be dispensed without a prescription as well. So for anyone who thought we already had this and didn't need it, that's why it would be coming back. All right, on the top of page 17, we have higher education and healthcare services. This would add a new chapter in Title 16, which is the education statutes. I think a number of you on this committee are also on the education committee, so you'll know Title 16. This would add a chapter 78, access to reproductive and gender affirming healthcare services. It starts out with definitions. So as used in this chapter, gender affirming healthcare readiness means each institution's preparedness to provide gender affirming healthcare services to students or assist students in obtaining gender affirming healthcare services, including having in place equipment, protocols, patient educational materials, informational websites, and training for staff, provided, however, that gender affirming healthcare readiness may include the provision of gender affirming healthcare services. Gender affirming healthcare services has that same definition in Title I. Institution, as used in this chapter, means the University of Vermont or a college in the Vermont State College system. We're talking about our public institutions, higher education. Medication abortion means an abortion provided by medication techniques. And medication abortion readiness means each institution's preparedness to provide medication abortions to students or assist students in obtaining medication abortions, including having in place equipment, protocols, patient educational materials, informational websites, and training for staff, provided, however, that medication abortion readiness may include the provision of medication abortions. So kind of the same concept for both types of services.
So do these protocols exist? They're saying they gotta have protocols. So is there something they're gonna have to
Well,
create?
So far, we've just got definitions, so then we're gonna look at what is being required of the institutions. Section 2502 is on gender affirming healthcare and medication abortion services readiness plans. This directs each institution to develop gender affirming healthcare and medication abortion readiness plans for its students. It directs the Department of Health to issue guidance to all institutions regarding the required contents of these readiness plans in accordance with the relative capabilities of each institution to provide services, including directly providing gender affirming healthcare services or medication abortions or both in a health center, providing referrals for gender affirming healthcare services or medication abortions or both, not provided in a health center, providing information to students about obtaining gender affirming healthcare services or medication abortions or both available off campus, and providing clinical and supportive care in a health center for medication abortions using medication lawfully dispensed through a retail or mail order pharmacy. So this is where the Department of Health is issuing guidance to institutions about what has to go into their plans. In developing that guidance, then on page 19, subdivision 2 directs the department to consider factors including whether the institution has an operational health center on campus, the institution's proximity to a hospital, clinic, or other facility that provides gender affirming healthcare services or medication abortions as applicable, the availability, convenience, and cost of public transportation between the institution and the closest facility that provides gender affirming healthcare services or medication abortions or both, and whether the institution employs healthcare providers on campus. Subsection 3 directs the Department of Health to review the gender affirming healthcare and medication abortion readiness plans annually, taking into consideration any changes to the capacity of each institution to provide services to students since the preceding approval of the plans. And it requires each institution to submit to the Department of Health annually any amendments or revisions to their readiness plans. Then on or before January 31st of each year, the bill requires the Department of Health to determine whether the plans are adequate in proportion to each institution's capacity. And the department shall further provide guidance to institutions with plans that are deemed inadequate that includes remedial measures for the institution to develop an adequate plan. So scroll down. Section 13 is the implementation provision for these gender affirming healthcare and medication abortion services readiness plans. Requires each institution to submit their first readiness plans to the health department on or before November 30th, 2024, and for the department to review the plans for suitability on or before January 31st, 2025. So it gives some lead time for them to get these plans together.
Might be over.
Are we at 16?
We can wait outside,
You're
so
probably good, maybe put the red little marker there, and then when you see someone come out, you can come back in. We're gonna go just a few more minutes, we might be 5 more minutes, and then we'll move on to FQHC. We're getting close. You're doing a great job. Senator.
Wonderful job. A question on section 13. Seems to be a mix of plans and implementation.
Yeah.
I don't really get, it's not really clear you have a plan, I get that from the previous section. Now this is, you're implementing the plan, we're not talking
No,
about.
this is actually implementing the plan requirement. So it just requires, it's when these start. So we have sort of a delay before the plans are before the first plans have to be submitted. So the health department can prepare its guidance, get the guidance out to the institutions, give them an opportunity to create their plans. So you'd be getting, about 18 months from when this might pass, if it passes this year, before those first plans have to be submitted to the health department.
So the implication about reviewing the plans for suitability means that they're approving the plans, so it doesn't say that exactly.
Well, right, so up above in section 12, in that subsection E, it requires the Department of Health to determine whether plans are adequate in proportion to each institution's capacity on an annual basis. So this says that the first January 31st that's going to be implicated is the January 31st of 2025. So when you read those together.
Double stamp, okay.
Right.
Okay.
So,
Okay.
all right. And the final substantive section before we get to the effective dates deals with prohibition on disclosure of protected health information. This is section 14 is amending an existing statute in Title 18 on disclosure of protected health information. And I'll tell you what's in here and then sort of tell you why it's in here. So it starts out with definitions. Definition of covered entity. I've just made a little word change there, but still has the same meaning as in 45 CFR section 160.103. So this is referring us to the Federal Health Insurance Portability and Accountability Act of 1996, which I think comes up in here somewhere. And that is HIPAA, for those of you who've heard of HIPAA before. So HIPAA is a federal law around prohibitions on disclosure of protected health information. And so existing law is already piggybacking on the definition of covered entity there. We pull in this new definition from Title I of legally protected healthcare activity, and then make another just grammatical change here to the definition of protected health information, which again reflects HIPAA. So under existing law, it says that a covered entity shall not disclose protected health information unless the disclosure is permitted under HIPAA. And we're adding in here in subsection B, except as provided in subsection C. So the general rule will still be a covered entity shall not disclose protected health information unless disclosure is permitted under HIPAA. That really just tracks federal law. So that existing law is not a change from what's required under federal law. But here in subsection C, we're now adding except as provided in subsection D, unless the patient or the patient's conservator, guardian, or other authorized legal representative, I'm just going to say legal representative from now on, explicitly consents. So unless the patient or their legal representative explicitly consents in writing to the disclosure, a covered entity shall not disclose any of the following in any civil or criminal action, in any proceeding preliminary to a civil or criminal action, or in any probate, legislative, or administrative proceeding, whether in or outside this state. So again, unless the patient or the patient's legal representative explicitly consents in writing, a covered entity, which is generally somebody who's providing or an organization that's providing healthcare services, shall not disclose any of the information on this list in any kind of legal, legislative, or administrative proceeding in or outside of Vermont. So it cannot disclose any communication made to the covered entity by, or any information obtained by the covered entity from a patient or the patient's legal representative relating to any legally protected healthcare activity, or any information obtained by personal examination of a patient relating to any legally protected healthcare activity. It requires a covered entity to inform the patient or the patient's legal representative of the patient's right to withhold written consent to disclosure of the communications and information. So again, in C, it says unless the patient or the patient's legal representative consents explicitly consents in writing to the disclosure, covered entity cannot disclose any of that information. And it also then in subdivision 2 requires the covered entity to tell the patient or the patient's legal representative that they can withhold written consent. Then subsection D says, notwithstanding any provision of subsection C to the contrary, the written consent of the patient or the patient's legal representative shall not be required for disclosure of communications and information in these limited circumstances described in subdivisions C1, A, and B of this section, pursuant to federal law, Vermont law, or rules adopted by the Vermont Supreme Court. So we're saying there's an exception to the general prohibition on disclosure, and that's if it is required by federal law, Vermont law, or rules adopted by the Vermont Supreme Court. Also, disclosure is allowed by a covered entity against whom a claim has been made or there is a reasonable belief will be made in a civil or criminal action, in a preliminary proceeding before a civil or criminal action, or in a probate, legislative, or administrative proceeding to that covered entity's attorney. So disclosure can be made by the covered entity to the covered entity's attorney or professional liability insurer, so the medical malpractice carrier, for use in the defense of the action or proceeding. So those are so far the instances in which this information can be disclosed is because federal or Vermont law or Vermont court rules require it, or the covered entity needs to share it with their attorney or their medical malpractice insurer because there is or is likely to be an action against them. Disclosure can be made to the Commissioner of Health for records of a patient of a covered entity in connection with an investigation of a complaint, if the records are related to the complaint, or if child abuse, abuse of a vulnerable adult, abuse of an individual with a developmental disability, or abuse of an individual with an intellectual disability is known or is in good faith suspected. And then it says in subsection E that nothing in this section shall be construed to impede the lawful sharing of medical records as permitted by federal law, Vermont law, or rules adopted by, again, the Vermont Supreme Court, except in the case of a subpoena commanding the production, copying, or inspection of medical records relating to legally protected healthcare activity. So what does all this mean? Well, if you're familiar at all with HIPAA, HIPAA already prohibits a lot of disclosures of protected health information by covered entities. But there are certain provisions of HIPAA that say a covered entity may disclose. It gives that choice to the covered entity about whether to disclose protected health information. And so this language would be saying, except Vermont law says you can't. So even though HIPAA says you may disclose, Vermont law says to the covered entity, you may not disclose. And this is really aimed at protecting patient information from being disclosed in the case of actions by out-of-state, under out-of-state laws. So that's why there's some provision saying if Vermont law requires it, that's okay, but we're not authorizing disclosure because an out-of-state court or otherwise is demanding it to the extent we are able to protect that.
So why don't we forego the effective
All right.
date at this time? And this is our first go through. It's been productive, lots of questions, and we have a lot of folks to hear from. So,
and I will note that last piece, the HIPAA, what I refer to sort of is as a HIPAA backstop, came from a Connecticut law passed last spring. So a lot of what you've seen comes from Massachusetts. This one comes from Connecticut.
and this will be consistent with what the judiciary bill has in it in the House. There'll be some overlap. Not particularly HIPAA, but other areas.
Right, this is kind of dealing with it from the covered entity angle under HIPAA, and the judiciary provisions are otherwise protecting information.
Just a process question. So does the bill come here first and then go to judiciary and then go?
No, yeah, no, that's a good question. So the bill that's in the House is a bill that has been put into the Judiciary Committee. It's totally different. I won't say totally different. It's a different bill. So it has a different jargon, it has the same definitions, but a different set of statutes and requirements.
Yes, it's really more of a law enforcement focus.
Yeah.
Judicial process.
We may not see that bill. I mean, we will look at it. Certainly we'll individually look at it. We may want to go over it at some point. I haven't foreseen that yet, but we may do that. And then this bill will be voted out of this committee. I believe that this is the last stop. It may be looked over by a couple of other committees, but it will probably not be taken in as far as I know. So that's how that'll happen. And then someone will be happy enough to report it up on the floor of the Senate and answer all the questions that you just asked. No, we have some ways to go. There are some folks we need to hear from, but this is our first stop, first time. It is new, it's different. I understand that, especially for folks who haven't been here during the Article 22 discussion or our gender affirming care discussion that we had last session, that this is totally new and may feel uncomfortable in some ways, but some of us are comfortable with this, and we're going to try and get to that comfort level so we can understand how we might improve the bill going forward. That's it. So we're good, I hope. And I'm happy to talk with anyone. Thank you both. It's a team effort, a good team effort. Appreciate your time. It was there. And we'll put this back up on the agenda sooner or later. I think what we'll do is we'll hear from the FQHCs briefly, and we're going to hear the federally qualified health centers. Yes. So, we did a little bit.
Proceed.
We don't get a break. Is what?
Is cheerleading allowed? I noticed that somebody at Florida was.
Oh, yeah. I just, if it gets too much, let me know. Yeah, if you don't like it.
It's a little distracting.
It was? Well, then
We got a little-
that's sufficient. Just let me know who it was.
I don't know.
Yeah, that should, that's
I'm
enough.
saying that you're all right.
Okay. Well, there are three of us here, and we do want, and I think we might get more coming in, which is
All
a
right.
good thing.
Well,
But
this,
Mary Kate, I don't think that you know our full committee.
I have not, there's definitely some new faces this year.
So Senator Gulick is out, and she'll be back in.
Okay,
Right, you know Senator
thank
Parks,
you.
and I'm gonna let you.
I'm Dave Weeks, representing Rutland County, and live in New York.
Excellent, nice to meet you.
I'm Terry Williams, I also represent the county.
Excellent. Excellent, nice to
Yeah,
meet you too.
you see, I got Rutland around. This is the backup team. So, why don't you introduce yourself and then
Yes.
we would be
I'm just,
happy.
yeah, I'm just waiting for someone to let me in.
Just hit admit. Behind it.
Can I
Wait,
touch
wait,
that
we
or-
have it. Okay, there we go.
All right, and I've got all of my buttons turned off, so I think we won't get any echo. For the record, I am Mary Kate Molman. I am the Vermont Director for Public Policy for Bi-State Primary Care Association. Sorry, I am, let's see. Continue that audio, got it.
Are you sharing?
I will be sharing, I've got a presentation. Oh, I'm disabled for sharing right now, so I can talk.
Okay.
That I-
You should have it now.
Do we have it here?
You should, I did share it.
You should be able to now.
I should be, okay. All right, and I'm going to do the slide.
What I'm gonna ask of you, so we can hear from folks from the free clinics is, you know, to spend 10 or 12 minutes, and then we'll have 12 or 10 minutes.
Okay, yep, I will move it along. So again, for the record, Mary Kate Molman, Director, Vice Public Policy for Vermont and Bi-State Primary Care Association. We are an organization that represents safety net providers in healthcare in Vermont. So we have the federally qualified health centers, we have the Vermont free and referral clinics, which you will hear next. And we also support and represent Planned Parenthood Northern New England, which Lucy Lurish was in the last meeting. But because you have these other folks also talking about their organizations, I'm going to focus on the federally qualified health centers, which I will say I have been in Vermont healthcare policy for 7 years, and I did not really truly understand federally qualified health centers until I started to work for Bi-State. So we're just going to jump in. What is a federally qualified health centers? These are organizations that were established under federal policy in the 1960s. They are set up to provide or make sure there is available primary care services and other additional supportive wraparound services in areas of high need. So there may be areas where there are fewer providers, fewer services, and that is really where the federal statute and our regulator, HRSA, the Health Resource and Services Administration, wants us to set up. As safety net providers, we must participate in Medicaid. We must serve all individuals regardless of their ability to pay and regardless of their insurance status. And we also are required to provide a sliding fee scale to anyone with at the 200% federal poverty level or less. We also really focus on integrated care. We are primary care providers, but we are different from other primary care, so hospital-based primary care or an independent, in that we really try to address the whole person. We take that novel approach that the brain, the mouth, the body are all one entity. So we provide mental health services, substance use disorder treatment, dental. We're actually required to provide dental by federal statute and regulation. We can either provide it in-house or we can contract it out, but that is one of the key services that QHCs must provide. We also do reproductive health. And as you talked in the last bill, there's a lot of reproductive support. Abortion gets a little bit tricky with some of our federal funding requirements and the Hyde Amendment. Won't go into that, but we also do provide gender affirming care. Many of our centers provide that. And also many of them have pharmacies. And also the primary care in that region. Oops, kick me out.
I don't think that was you. I think it's probably some technical something.
Okay.
Yeah, their Wi-Fi is weird.
Yeah, it's slow to find it.
Okay. I'll try to get back to that, but
We also have it on our webpage.
excellent. All right. So we also, so again, there's that strong community focus, and we all of that for use disorder, and we're 9 out of our 11 members are participants in One Pair Vermont, the old pair model. The 2 that don't are our smallest members, and they just, that volume is hard to participate. So where are we? We are in every county across Vermont. And and again, those are our services, but that just gives you a sense of where we are. We recently opened urgent care up in Newport. We have urgent care in St. Albans. We have a couple other looking to expand more into Brattleboro and open an urgent care in Brattleboro. So it's a statewide presence with those background services. Yeah.
Just curious, are these organizations private who have joined into a network, or are they public? Fully, public supported or public funded? I'm just not sure.
So they are nonprofits. They're all nonprofits. They're required to be nonprofits. They have, and I can get into the funding. I've got a slide a couple down. That'll probably get a little more at your question. So who we serve, again, the federally qualified health centers, we have over 184,000 patients and over 700,000 visits. We serve more than 2/3 of the uninsured in Vermont. Our Green Grove clinics would also support our uninsured in Vermont, but we also provide that underinsured. And going back to that sliding fee scale, that's to help reduce the prices for the uninsured. It also helps reduce the cost of the copays and deductibles for people under 200% federal poverty level. This is your slide.
Can you do that one though?
Yeah,
Because,
sure.
So, again, just trying to get my head around this. Do the FQHCs, are they targeting the uninsured?
They are
Slides only?
available for everyone.
Okay, but
So,
what are they? Go ahead, I don't want to be interrupted.
yeah, no, I mean, they're available for everyone. We accept Medicare, Medicaid, commercial, uninsured. And there's no limit to if finances should not be a barrier to
Okay,
receiving
so
care.
this slide here about who you serve,
Mhm.
is this in an annual basis or whatever the time frame is?
Yeah.
These are the folks that come through the door?
Yep.
Okay, very good.
All right, funding sources. So as federally qualified health centers, to be recognized as such, we have to go through a very competitive national application process. And when you get recognized, you are then eligible for what we call the 330 grant, and this is from the Section 330 of the Social Securities Act. This grant supports operations. It supports, it makes what the sliding fee scale available. It allows health centers to provide free care to patients, so free dental services. Rutland does a lot of free dental for patients in that area. In Burlington, it's a lot of like the outreach to the homeless, translation services, transportation, some of the school-based. So if a kid needs services in the school, and it may be for services that they are protected from having to share with their parents, and they don't want that explanation of benefits to go back to the parent, health centers can provide that service free of charge to that minor. Our Medicare and Medicaid rates are done through a prospective payment. So for Medicaid, and I'll get into this a little bit more in my next couple slides, but all of the Medicaid covered FQHC services are covered under a single encounter rate. So you can go in for 2, you can go in for 20 of the covered services. The federal, the health center gets that same encounter rate. Commercial, we receive the same fee for service or other reimbursements that other primary care receive. We also receive some revenue or savings really through the 340B program. And I don't want to that's like a whole nother hour of presentation, but that is a federal pharmacy program that allows FQHCs to retain they get the drugs at a lower price than what they may get reimbursed from by the payers other than Medicaid. That's a different thing. But then that savings has to be used, is required by federal law to go back into services for patients. Accountability. We are highly regulated. We do not fall under the Green Mountain Care Board. We have HRSA. We love HRSA. HRSA is very hands-on.
Maybe you should translate HRSA.
Yeah, hold on. Health Resources and Services Administration. And we have a compliance manual that they've got. So this is our compliance manual of all of the different regulations that we have to follow. There are over 90 regulations. That is in addition to patient-centered medical homes. That's in addition to other, like One Care Vermont. And then every 3 years, we get a site visit from HRSA. And these are, the details of some of these questions are mind-boggling, but these are all of the different things that our members have to comply with to maintain their FQHC status and receive that grant funding. Yes.
So before you flip to the next slide, I want to catch it. So going back to the question, which I think this illustrates it well, about who's essentially supporting the centers.
Yeah.
It looks like roughly 30% is either self-pay or commercial. The remainder is public.
Yep.
Funding. Okay, that's helpful. Thank you.
So Medicaid, Medicaid, and this may be a little foreshadowing. Medicaid funding is supposed to cover 100% of the cost of Medicaid covered services. And again, those are services in Vermont that covers your primary care, ambulatory care, and mental health. Dental is reimbursed through a separate funding mechanism. And these costs have to be reasonable. And so reasonable is defined quite extensively by Medicare. This gets a little bit at what I was just saying. So these encounter rates cover the full spectrum of Medicaid covered services. Again, Vermont, that's primary, ambulatory, and mental health services. This encounter rate under federal statute has to be increased by the Medicare Economic Index inflation factor. And that is so that this rate can, in theory, keep up with the 100% of cost that I just showed you in the last slide. That is not currently the state of, the rate of inflation versus Medicare Economic Index. Right now, we did an analysis of the 2021 data, so looking at our cost reports versus our reimbursement, and there's about a $14 million gap between reimbursement and cost. I will mention. And I will say that that grant funding received is intended for our uninsured and underinsured. It is not intended to supplement Medicaid reimbursement. This was a budget adjustment act request that we just had approved by the House Appropriations Committee. DEVA historically, Department of Vermont Health Access historically has used the previous year Medicare Economic Index inflation factor. We've asked them to use the 2023. So the governor's budget includes the 2022. We're asking the legislature to please use the 2023. Yes.
Can you go back one slide just
Sure.
for context? So this gap, if it's federally required, why aren't you chasing our federal delegation for funds?
This is Medicaid. So this is where
Medicaid flow through.
it's managed by the state.
Okay, thank you.
Yeah.
And the federal government, we don't get as much money as other states. per
Yeah.
capita. So we're
So-
stuck.
Feds match it, but states set the policy for Medicaid.
Yeah.
So the BAA, it's a fairly small adjustment, but that's in the spirit that the BAA is supposed to be a technical adjustment. We'll be coming back to discuss more broader policy implications. And then I'm part of a primary care association. We are also supported by federal grant by HRSA. We are designated by HRSA to support federally qualified health centers. We are present in every single state. Each state has its own primary care association. There are some that cover 2 states, like bi-state, Vermont and New Hampshire. There's one that's Delaware and Maryland, and the other one is Dakotas. And I call this out, you can see what we do, we're technical assistants, I won't read all of this, but I call this out because the network of primary care associations across the country, we are very dialed in with that group. And it's really interesting to hear from them how their FQHCs are responding to healthcare reform efforts. For example, we had a nice conversation with the Maryland PCA and the Pennsylvania PCA, and those are, again, kind of foreshadowing and looking at you, Chairwoman. But we are an entity that is, that our similar entities are present in every single state. So these are kind of two key sources for you guys to look at if you would like. And that's my contact information if you have any questions. I believe I've probably pushed my time, but.
No, you've done a good job.
Okay.
Great, perfect. Yeah, thank you. This is a good introduction.
Yep.
I know we'll hear more as we go ahead. And just let us know as we go through various bills, it'll be important for you and others. I know Sarah's reached out already and others have reached out. So just to reach out as we go through things.
Yep.
Let us know what.
And the last thing I'll mention is you'll see the last reference slide. You can look up your name and see which health centers are in your district.
Good work. You have another speaker coming or?
Yes,
We do, but did you, what did you? That's okay.
well, you could ask it and then we'll say we'll get another time, but.
No, they were, I was just curious if there was any requirement or norms around BIPOC folks being included on them. And my other question was how your workforce is looking.
There's no requirement, but they do really try to have the board of directors and those patient numbers representative of the patient population. Workforce, it's a struggle. We're struggling with like everyone else. It's all from the MDs all the way to the front office staff. If you may have the MDs, you may have the nurse practitioners, but you may not have the staff there to bring patients in. We've had examples of doctors rooming their own patients, taking their weight and blood pressure, which is not typically a doctor working at the top of his or her license. And dentists, especially dental hygienists. We can potentially get the dentist, but you may not have the hygienist that you need to see all the patients.
Thank you.
Thank you.
Yeah, so workforce will be coming soon.
Yep.
All right, so we have Olivia Sharrow and is here, and Dan Barlow is here. Do you want to come up together?
Is that okay?
Yeah, it's very, very fine.
Thank you.
To fall asleep in the just the conversations.
Yeah.
And that's why we have too many people in these rooms. It's like literally the air. It's really bad.
Yeah, no, I was glad that the shutters got shut a little bit.
The sun is awfully nice. I haven't seen it very much this way.
So let's get started. And one of you, I think you don't know everyone, so let's introduce ourselves first. And I'm going to start. Jenny Lyons, I am a senator representing Chittenden Southeast and chair the committee, and then we'll just start over here.
So I'm Ruth Hardy from Madison District.
So Dave Weeks, Roland County from Proctor.
Martine LaRocque from Burlington, representing Chittenden South, no, Central.
For the record, Dan Barlow, I'm the executive director of the People's Health and Wellness Clinic in Barrie.
Also, for the record, I'm Olivia Sharrow, the executive director of Vermont's Free and Referral Clinics, which is also based in Barrie.
Please introduce yourself for the record. I just need to talk.
Sure.
But please introduce yourself for the record, and then we really do look forward to your testimony. So, yeah, great.
Go ahead. You already introduced yourself.
Great. So I'll get started. Vermont's Free and Referral Clinics was founded in 1995 under the name the Coalition of Clinics for the Uninsured. Today, the nonprofit association has expanded to include the 9 healthcare clinics across Vermont that provide free healthcare services. The history of the FRC and its members is rooted in reducing barriers people in Vermont face when trying to access care, and you can still see this in our work today. A lot has changed in the last nearly 30 years, but our members still have several critical roles. Free and referral clinics serve as entry points into the larger healthcare system. They operate as safety nets, and they also provide vital preventative and primary care services, particularly to patients experiencing marginalization elsewhere in the healthcare system. An important thing to understand is that the member clinics are all independent organizations. So when I talk about services, they do vary from clinic to clinic. But broadly, the 9 clinics offer free clinical services, free medication, care coordination and case management, insurance enrollment assistance with both state and federal programs. And they also help patients enrolling in financial assistance at our local hospitals. We're primarily funded through a legislative appropriation. It comes to us as a grant and it's managed by the Department of Health. But for many of the free clinics, this is only part of their funding, and Dan will talk about that a little bit more. Our grant amount was generously increased last year, and I just saw also this year was level funded by 10% to a little over $1.1 million. We leverage this funding and more in many ways, including saving the state an estimated $3.9 million in avoided emergency room costs. You can see using these numbers that for approximately every dollar appropriated invested in our work by the legislature, we saved the state $4. In 2022, we cared for 11,542 patients. This was approximately 1,500 more than in 2021. Of those, 4,385 patients were new. We're also seeing those numbers increasing, which tells us that we're still meeting, new patients are still finding us. There's still an increasing need in our communities. We provided 41,000 instances of patient support, and this is an average of about 4 services per patient. This has also increased from past years. And all of this work is provided by 32 paid staff across the 9 clinics and nearly 270 volunteer clinical and clinical support staff donating time valued at nearly $500,000. And I'll say that is, we think, an underestimate. The clinics are free. Care is provided mostly by volunteers, and I'm sure you can, as you can imagine, this can be challenging. There's a limit to our funding. We can't just increase the amount of money we get as we see patient numbers increase. But there are benefits to this, and the independence of the structure does mean that the clinics can be agile and can shift services and programs to meet changing needs in their communities. I've focused up until now on the positives and the quality of care and the passion of both staff and volunteers can't be overstated. But because of the nature of our work, we also are on the front lines seeing concerning trends within our patient populations that we believe is reflective of what patients are dealing with elsewhere in the healthcare system. 43% of patients are currently underinsured. This is a significant increase from 2021. We expect these numbers to increase even more as Medicaid continuous coverage ends and Medicaid closures begin. Hand in hand with this, we're seeing at some clinics, the average incomes of patients go up as the cost of living and cost of accessing care elsewhere increases. 26% of our patients arrive reporting delayed care. This is both due to cost and because of the inability to access providers. We're also seeing bottlenecks with patients getting set up with primary care practices long-term. And finally, we're seeing ongoing and in many cases increasing challenges with patients accessing dental and mental health care. And this is something else that Dan will go into a little bit further. To finish, there are 2 takeaways that I hope I can leave you with as you think about your work over the next 2 years, and also how VFRC and the free and referral clinics fit into the healthcare system in Vermont. Our patient numbers can seem small, but I think it's critical to understand that they represent some of the most complex cases, some of the highest needs, some of the highest potential costs, and some of the highest barriers in accessing care across the state. Furthermore, data from the clinics can provide really valuable insight into the health of the system as a whole and can act as signals, illuminating the experiences of those on the margins and encourage us to ask challenging questions of ourselves and of our current system. So, thank you for your time.
Thank you for your work. Was Dan, were you gonna?
I was just gonna say I'm about,
Okay,
I'll hand it
do
over.
that. Yeah.
Thanks, Olivia. I want to build on a few things Olivia talked about. So the People's Health and Wellness Clinic, we're located in downtown Barrie. We've been in operation for 30 years. Last year, we saw a little over 400 distinct patients. That's an increase for us. We're seeing increases year after year. We are a small staff, about 6 employees, representing 3.5 full-time jobs. And as Olivia said, most of the care is provided by volunteer doctors and nurses. We have about 40 volunteer doctors and nurses. Some of them retired, some of them near retirement age. They like to keep their license active and give back to the community, and that's why they volunteer at the clinic and other clinics like ourselves. Couple trends that we are seeing that are really concerning. 15 years ago, 90% of our patients who came to the People's Health and Wellness Clinic did not have health insurance. Obviously, that was before the Affordable Care Act. Last year, more than half of our patients had health insurance, either Medicaid or a private plan, but they could not find a primary care provider or afford the out-of-pocket cost to see a doctor. And so they're coming to us. And as Olivia said, we are a free clinic. We cannot charge for our services. So when we see increased patient demand, it's difficult to find the financial resources to fill that gap. Our budget for each year is about $420,000. Our state allocation is about 1/3 of our total budget, and the rest is fundraised through community donations, grants, and town meeting municipal allocations as well. So we're constantly fundraising to keep these clinics open. We are also seeing some real crises in oral health. About 5 years ago, we added oral health care as a program at the clinic. We have a part-time dental hygienist on staff. She sees about 4 patients each day, so about 12 patients a week. And this is where we're seeing some the problems in our healthcare system manifest. A great example is just this month, we had one patient come in, had not seen a doctor in her adult life, was concerned that it was hopeless for her teeth. Luckily, she found out she just needed a cleaning, a few cavities filled. That's a success story. The same day, we had another patient come in her early 30s, and she found out that she's going to need all her teeth extracted. We cannot do extractions at the clinic. That's surgery. We just have a dental hygienist, so we often have to refer out for that work. The one problem that we are encountering is our patients are unable to afford implants or dentures. It costs about $2,600 for a nice pair of dentures, top and bottom. We can usually find $400 or $500 through a Catholic charity to help out. But that gap for our patients, who are the most vulnerable people in Vermont, is impossible to fill. And my dental hygienist, I had a promise I would bring this up to this committee today, if there's any possibility of using state Medicaid dollars to buy dentures for our patients. Because if you put $1,000 toward a pair of dentures through the Medicaid allocation, our voucher for $400 or $500, suddenly our patients are in reaching distance of actually being able to afford a pair of dentures. And what we're seeing in our oral health care program is, again, people coming in who are not, 60 years old and a lifetime of problems with their teeth. These are people in their 30s who are coming in and have not seen a dentist in 10 or 15 years and finding out that they need all their teeth removed. These are people who are, the masks are coming off. They want to go work. They want to participate in their community, and they realize the condition of their teeth is holding them back from doing these things. This is a real crisis in our state. I know there's many worthwhile causes within our healthcare system. If we did have additional funding, I could bring in my dental hygienist for 2 more days each week. That's 8 more people each week seeing our dental hygienist, getting preventative care, and not showing up, in a couple of years at our clinic and needing major surgery.
And we in here are pretty aware of the dental issue, but thank you for the very specific need that, the $1,000, that'll do a lot. But who knows if we can get there. I was gonna bring it to closure because we are after time, but if you have a quick question.
Yeah. So thank you. we 2-3 years ago now increased the Medicaid dental benefits to $1,000 actually. And so is that not, you just mentioned if you had $1,000, there should be $1,000 through the Medicaid program for dental.
My understanding is they cannot spend that on dentures. That's only for preventative care.
Preventive care.
I think it's also for, I don't know specifically about dentures,
Yeah.
but it's not specific. I don't think there's a requirement that it only be preventive, because it also would include, cavity filling and that type of thing.
What I know is that you cannot spend that money on dentures.
Okay, so we're gonna track that one down. That's a good question. And I just want to say thank you to both of you for first being patient with our legislative time.
Yeah.
And then also being here to provide this information, as I know you do terrific work. It's not easy. And it is so important to so many low income and very, I'll say needy, but they are very needy folks in our state. So thank you for that.
I do want to also just thank the committee. I spent about 15 years here in the building as a journalist and then a lobbyist, and I know how thankless this job can often be for folks and how much you all give up to be here each winter. So thank you.
So Alex, we are going to go offline, and I'm going to say thank you to everyone, and we've had a great day. A lot to ponder, a lot of happiness. Go get your cup.